Hey everybody, welcome back. This lesson is about the vasculature of the neck as seen in CT imaging in the axial plane. But first, we'll start with a maximum intensity projection. A maximum intensity projection, or MIP, is helpful because it can be used to create the appearance of a 3D image. The arterial structures of the head and neck start directly or indirectly from the aortic arch. There are three vessels that branch directly from the aortic arch. Blood flows through the arch from right to left, so we typically name them from right to left. The first branch is the brachiocephalic artery. The name tells us what this vessel supplies. Brachio means arm. Cephalic means head. The brachiocephalic artery immediately branches into the right subclavian artery to supply the right arm, and the right common carotid artery to supply the right side of the head. The next branch of the aortic arch is the left common carotid artery. It's exactly like the right common carotid artery in every way, except that it branches directly from the aorta. The last branch of the aortic arch is the left subclavian artery. This artery supplies the left arm. Again, it's exactly like the right subclavian artery, except that it branches directly from the aortic arch. The right and left subclavian arteries are the origin of the right and left vertebral arteries. The vertebral arteries travel through the vertebral column by way of the transverse foramina within the transverse processes of the cervical vertebrae. The vertebral arteries eventually converge at the base of the brain to become the basilar artery and supply the posterior side of the circle of Willis. At about the level of C4, the common carotid arteries bifurcate. That means they divide into two branches. The larger branch is the internal carotid arteries. They enter the skull base through the carotid canal to supply the brain and eyes. The internal carotid arteries supply the circle of Willis in the brain. The smaller branch of the common carotid arteries is the external carotid arteries. They have several branches which supply the tissues of the face, scalp, mouth, and jaw. All of these vessels can be seen in the axial plane. This is an axial view of a CT angiography study of the neck. The patient has been injected with a large, dense bolus of iodinated contrast. The scan has been timed so that the arterial structures of the neck are brightly opacified with contrast. We'll still be able to see the veins of the neck, but they won't be as bright. First, notice this ultra-bright structure. It's the superior vena cava. It's so bright because contrast is being injected through the patient's right arm. This contrast is dumping into the heart through the superior vena cava. It's still very dense and not very diluted in the patient's blood. In fact, it's so dense at this point that we can see black streaking artifacts around the superior vena cava called beam hardening. This brightly opacified structure is the aortic arch. It has an oblong shape at this level. As we follow the scan upward, we will begin to see arterial branches coming from this structure. Take note of the surrounding anatomy. We can see this air-filled trachea. We can also see this tubular structure, which is the esophagus, moving superiorly by a few millimeters in the direction of blood flow. Now we can see the three branches of the aortic arch. We typically name them from right to left in the direction of blood flow. The first branch is the brachiocephalic artery. Above this level, the brachiocephalic artery immediately branches into the right subclavian artery to supply the right arm and the right common carotid artery to supply the right side of the head. The next branch of the aortic arch is the left common carotid artery. This supplies the left side of the head. The last branch of the aortic arch is the left subclavian artery. This artery supplies the left arm. We can again see the air-filled trachea, and we can also see the esophagus, moving superiorly in the axial plane. This image is at the level of about T1. We can see all four of the principal arteries that supply the head and neck. We can see the right and left vertebral arteries. These vessels originated at the right and left subclavian arteries. Above this level, they are going to enter into the transverse foramina of the cervical spine, travel into the cranium at the foramen magnum, become the basilar artery, and supply the posterior side of the circle of Willis. We can also see these brightly opacified right and left common carotid arteries. The right common carotid artery originated from the brachiocephalic artery. The left common carotid artery originated directly from the aortic arch. Both of these vessels will eventually bifurcate and supply various aspects of the head and neck. These arterial vessels all look perfectly normal. They are all round with smooth edges and totally opacified with contrast. We can also see some venous structures. We can see the right and left internal jugular veins. These veins receive most of the venous drainage from the head and neck. At this level, they are not bright because the scan was timed to demonstrate opacified arteries, not opacified veins. Veins become opacified with contrast several seconds after the arteries. The internal jugular veins almost always are the largest and most lateral vessels of the neck at this level. Take note of some of these surrounding anatomy. We can still see that air-filled trachea bounded on the right and left by the lobes of the thyroid. The thyroid appears bright because it rapidly absorbs iodinated contrast. Moving superiorly in the direction of blood flow, we can see all of the same structures, but their relative positions have changed. We can see the right and left vertebral arteries. They are inside of the transverse foramina of the transverse processes of the cervical vertebrae. They will eventually converge to form the basilar artery and supply the posterior side of the circle of Willis. We can see the right and left common carotid arteries. We can see the right and left internal jugular veins, the primary vessels draining the head and neck. Notice again, they are the largest vessels of the neck. Take note of the adjacent anatomy. We can still see the trachea filled with air. We can also see the right and left plates of the thyroid cartilage. In this patient, the thyroid cartilage is bright from calcification. Moving superiorly in the axial plane, we've jumped several levels. Some anatomy looks the same, and some is beginning to look different. We can still see the right and left vertebral arteries within the transverse foramina. We can see the right and left internal jugular veins. They have moved posteriorly compared to the previous level, but they are still the largest vessels of the neck. At this point in the scan, they appear slightly opacified with contrast. That's because we are now late enough into the injection cycle that contrast has made its way into venous drainage. Notice that something has changed in the carotid arteries. On the left side, we still see the left common carotid artery. On the right side, the right common carotid artery has now bifurcated into the right internal carotid artery and the right external carotid artery. The internal carotid arteries enter the cranium to supply the anterior side of the circle of Willis. The external carotid arteries divide into numerous branches to supply various aspects of the face and scalp. Moving superiorly for one more axial view, everything is back to looking symmetrical. We can see the right and left vertebral arteries within the transverse foramina. We can see the right and left internal jugular veins, the largest vascular structure of the neck. They are even brighter at this level because we are getting still later into the scan. We can see the right and left internal carotid arteries. They are directly medial to the jugular veins. And medial to the internal carotid arteries, we can see the right and left external carotid arteries. Thanks for watching. That's been a review of the vasculature of the neck in the axial plane as seen in CT imaging.